God morgon. Hoppas ni haft det bra. Ja, välkomna. So I'll switch to English. I'm very happy to present Janet Reynolds, Dr. Janet Reynolds from Canada. She's the medical director at her clinic, the Crowfoot Village Family Practice.
That's correct, yeah.
And she's also the medical director of the Calgary
Foothills Primary Care Network.
Exactly. And she's also built the co-chair for Choosing Wisely Canada Primary Care.
Yeah.
And that's what you're going to tell us about more today.
Yes.
Thank you.
Yeah. Thank you. Hey. That's all I will say to you. Good morning, and thank you so much for having me. I've come from not quite as far as Dr. Kidd, but I've come from far away to tell you our story. And since I have the mic, you have to indulge me with a few reflections from yesterday. So I did not get to tour the KI, but I got to tour the JS, which is Dr. Jansen's clinic, and she blew my mind. And I just want to, it's so interesting that we're all family physicians. I'm a family physician, you're family physicians, but we're not the same. So at Sarah's clinic, I learned that your residency is 5 years long. My residency was 2 years long. And when they tried to make the residency in Canada 3 years, there was an uproar. It was not going to happen. So we have the shortest family medicine training in the world, I think. This is in no particular order. I got to see Sarah's exam room, which is one room where she sits and the patients come in and out. And in my clinic, I work with 3 exam rooms and I go in and out and the patients come in the room. So that was very interesting to me, and we would never have an unused exam room where a patient wasn't sitting in the room. And you have an ear room with fancy equipment, and we remove wax from patients' ears with a little squeeze bottle that just we do that way. So it's fascinating to me. The other almost more fascinating thing is that I was told that in Sweden, family physicians are paid on par, if not better, compared to other specialties. And in Canada and in my province where I live, family physicians are the lowest paid physicians, even though we think we work the hardest. You sing at dinner, and you sing at your conferences, and you sing like angels, and that would not happen in Canada either. And then if anyone here is using Google AI, I would like to hear from you after, because according to Maria, you're talking about mushrooms. According to the researchers that spoke when I was using the Google Translator, mattresses are important for depression treatment. And there was a fair number of F-bombs that got dropped into the Google AI Translator, and I'm not joking. Okay, so those are my reflections. And I will tell you the Canadian story about choosing wisely. So if we were in Canada, none of us, you would all be Canadian family doctors, and none of you would be paid to be here. You would be here because you have to participate in continuing professional development, and you do that on your own time. Thank you very much. So you would all show up to a conference because it's a good way to meet old friends, make new friends, learn from each other, and get your credits that you have to have every year. Because those programs are accredited, we have to give a disclosure so that I tell you about my biases. So I do get paid by Choosing Wisely Canada to be the primary care co-lead. I wish my co-lead was here with me. Her name is Dr. Guylaine Thériault. She's from Quebec, and she's a force to be reckoned with as well. I'm a family physician at Crowfoot Village Family Practice, this large practice in northwest Calgary, Alberta. And the owners, who are physicians of that clinic, pay me to be the medical director. And then I get paid to be the medical director for the Calgary Foothills Primary Care Network. And you need to know that because that might influence my talk. And it will greatly influence my talk because I'm going to talk to you about choosing wisely. So Choosing Wisely Canada is just this. It's the voice, the national voice for reducing unnecessary tests and treatments in Canada. And our vision is that we have high-quality, sustainable healthcare for all Canadians. And together with clinicians, patients, and healthcare partners, we can reduce unnecessary tests and treatments, support high-quality care, and contribute to the sustainability of our healthcare system. Choosing Wisely in Canada gets some funding from the federal government as well as from the Canadian Medical Association. That's the national medical association that represents all physicians. And then the home for our small but very mighty team is housed out of the University Health Network in Toronto. I will talk to you about Choosing Wisely in primary care, but I actually can't tell you this story without talking about Choosing Wisely in general, because we believe that we're better together. And I was picking up yesterday that maybe I was reading between the lines or listening between the lines, but that there's very much this sort of movement to improve primary care and research in primary care, which is so important for you and for us in Canada and all over the world. But our Choosing Wisely movement is that we're all better together and we all have that same common goal. So I was wondering if I was going to challenge your thinking or maybe stimulate you to think a little bit differently today. We've just rebranded, and this is our new brand. And this might be a poster, or this might be what we would promote in our webinars. And it's less but better. Better for patients, better for the system, and better for the planet. So in case you don't know much about Canada, I did think I had to give you a little bit of context. So Google AI tells me that the country of Sweden would fit into Canada 22 times. So our geography is very, very wide, east to west and south to north. We have about 40 million people. About 75% of our population lives within 3 hours of the American border. We don't like to talk about that right now. Most of our healthcare is delivered provincially. So the green Choosing Wisely, we call it our thought bubble. And that's where we have a local regional Choosing Wisely hub. The hub means that there is some clinician, usually a physician, who has the Choosing Wisely portfolio as part of their job, and they may or may not have support. But I hope you'll see soon that part of the way we spread our little tentacles all over the place is by partnering with really important people in the health system. I think that's all I wanted to tell. Oh, where I'm from is Alberta, so the one little thought bubble that's a different color, close to the west coast. Well, we are landlocked where I'm from. There's not a lot of water, but we do have the Rocky Mountains. So we've really matured in Canada around the co-benefits of Choosing Wisely. And for us, it's not about money saving. It is about stewardship. And the definition of stewardship is to look after something. So we want to be good stewards or good caregivers for our healthcare system. And we see these four benefits. The first one would be to reduce potential harm. I think we historically, in modern medicine, have kind of underestimated or underemphasized the harms that we can do to patients inadvertently, and maybe overemphasize the benefits, especially with technology. So just because you can have a total body MRI, can you do that here? In Canada, people can pay for a total body MRI to find out everything about themselves. They can't get their genes tested, but they can do that. That's not publicly funded, but just because you can, it doesn't mean you should. We are trying to protect a very finite resource, which is our healthcare system. So depending on the province, we spend about 40 to 45% of our tax dollars on healthcare in Canada. We are definitely wanting to ease the workload burden, which is a very hot topic around the world with a worldwide shortage of healthcare providers and a pandemic of burnout after the global pandemic of COVID. And we really want to reduce the healthcare impact on the environment. So planetary health is really critical. We do it 4 ways in Canada, and the first is that clinician engagement. So that's where we engage with all physicians, and we're expanding beyond physicians, pharmacists, nurses, dentists, all have lists. So we engage with a broad variety of clinicians across the health system. And so we have over 85 societies represented. So the society that would represent family medicine is the College of Family Physicians of Canada in that list. The societies make lists. You're going to hear about your new list that's coming out. I'm very excited about that. We have over 560 recommendations. One point I want to make here is that although we have a family medicine list, there's a recommendation in almost every other list that applies to me as a family doctor that does most of the diabetes care in Canada, most of the hypertension care, heart failure care. I see people with low back pain. So my list is a list of 14, but I think there's probably 400 recommendations that I could look at that are relevant to me as a family doctor. And we have a very engaged group of medical students with a Choosing Wisely. In our medical schools, the medical students create their special interests or like clubs. And so there's a Choosing Wisely club called STARS in all of our 17 medical schools in Canada. So this is a picture of our STARS. STARS stands for Students and Trainees Advocating for Resource Stewardship. They are very engaged and powerful, and it's because of these STARS students that Choosing Wisely spirit is in the curriculum in medical schools in Canada. They develop programming, they bring in speakers for their colleague medical students and so on, and it's this group that actually first highlighted the planetary benefits of the Choosing Wisely recommendations and did back of the napkin carbon emission calculations just to show that we can show that Choosing Wisely is better for the planet. This is really just to show you that there's lots of societies, they all participate, and they're there. It is the societies that are responsible for creating their own list, and they look at three things when they're creating a list. The first would be that there's no scientific evidence for a specific test, that there's data that the test is actually being used, if not overused, and that there's potential for patient harm. And that's how those lists are generated by our societies. And I think that's all I want to say there. Again, it's maybe too late. I hope not too late for the planet, but we're very pleased that we have over 40 of our recommendations that are considered climate conscious, so they have a little green leaf next to them if that's how they are. And the second thing that we do at Choosing Wisely is we look at implementation at scale. We want this to a big country, left to right, up and down, and so we really want to be able to influence broadly in the health system. The example that I'm going to tell you about is about blood transfusions. I can't remember the last time I ordered a blood transfusion as a family doctor, maybe for a palliative patient. But in Canada, family doctors work in all other aspects of the health system as well. They may in their small town be the hospital doctor and the emergency doctor and the palliative care doctor as well. So in about 2020, Choosing Wisely started a campaign, and it was really just a challenge. Don't transfuse 2 units of blood if one unit is good enough. And that turned into a bigger campaign, and now we have a hospital designation program where if hospitals are meeting the targets as designed by the designation program, they get like a Michelin 5-star rating as a Blood Wisely hospital and the designation. So there are almost 300 hospitals in Canada that participate. About 170 of them have this designation. And they're responsible for about 80% of the red blood cell transfusions in Canada. We've just done a big evaluation, and this kind of knocked me off my feet. So we estimate that with this campaign, we've avoided 45,000 units of blood, which is like a very precious resource, really. We've cost averted about $58 million, and according to today's currency, that is like 400 million Swedish krona. That's a lot of money, right? Yeah. and avoided about 335 tons of CO2 emissions with all of the single-use products that go along with collecting a unit of blood, processing a unit of blood, and then giving it to a person. So that's scale, implementation at scale. We are partners with our patients. We have a lot of wonderful patient partners that sit on our team, and we always engage them, especially in any of our print materials. They come to our meeting. Our national meeting is later this month in Winnipeg, if you want to come. And we will have a lot of patients there, and they help us with our public advocacy as well. This is a poster that was in a doctor's office probably a few years ago, and I don't know if there's a pointer on here, but if you see the poster in the middle that says "More is not always better," a big hot dog with way too much mustard, that was our initial campaign. And then we realized that we have a very diverse country, and that doesn't actually resonate with everybody, so we've evolved to the less but better campaign. Our posters get sent out to family physicians in the mail. At a conference like this, we would have a booth and people would come grab copies of posters and other print material. Here are two other of the posters that we've developed, and these are translated into 5 of the most common languages spoken in Canada. So sorry, but no amount of antibiotics will get rid of your cold. We've ditched the dipstick, and so that's about not doing urine dipsticks for older adults. Most of them have bacteria in their urine, and you will falsely treat their UTIs. So that's a new campaign that we're working on as well. And patients have had input. So the colors are purposely chosen so that these stand out. And as I said, they're translated into common languages. And then we participate in overuse commentary. So we'll write op-eds for newspapers and so on and so forth. And that's how we do the patient and public engagement. Then we look at measuring impact. So the Blood Wisely was another good example of that. But moreover, the original report, this was published in 2017 by Choosing Wisely Canada and CIHI, our Canadian Institute for Healthcare Improvement. And they estimated that up to 30% of the tests, treatments, and procedures associated with 6 of the selected Choosing Wisely initiatives were potentially unnecessary. So that was kind of devastating, but that's what it showed. And then we had a follow-up report. The 2 reports are kind of like not apples and oranges, but 2 different kinds of apples because the pandemic happened in the middle. So there was a lot of influence by the pandemic. But this follow-up report was really important to us at Choosing Wisely because, we believe in our cause and we put a lot of effort and work into it, and it'll be nice to know if it's actually working. The good news is it is working, actually. So in this report, it's 8 out of 12, and the other one it was 6. I think I said. But we have shown that we've significantly reduced, so more than 10% reduction in 8 out of the 12 tests that we were looking at. And we don't have perfect data from across every province, but we do have some. And so where we do have it, we get to show you this. I probably shouldn't talk to you about anything in healthcare without talking about the social determinants and how that influences the health that we deliver. So for Choosing Wisely, there's an interesting dichotomy where we have an example where we have overuse of one thing because of underuse of another thing. And the example we like to bring up here is we are overprescribing inhaled medication because we're not doing enough spirometry. And we're not doing that because we don't know we should or we don't have access to it, depending on where you live. And so that's kind of interesting. We have a very culturally diverse country in some places. And so culture and language can be a big barrier. And again, I learned yesterday that Google Translate will not replace my language line, which is very cumbersome, but it's not reliable. So language barrier is a problem. And then there's a movement about, there's a movement that I'm calling mistrust in the health system. So I don't know your social media influence here, but there's a country south of us, and there's very popular people like actors that work there, and they can get on the stage and say, you need to buy my big green egg, or, just there's crazy social media influence. And that's actually, and then there's the social media algorithms that as soon as you read one thing, then you get all of the information about this other misinformation, and there's, people are drawn to that. So that's kind of contributed to our mistrust from our patients. And then the last ugly truth that I'll tell you about is our Indigenous population in Canada. There are significant disparity in access to healthcare for our Indigenous people, and there are many, many reasons for it. Not the only one is the intergenerational trauma that's been created. But in Alberta, the province where I live, an Indigenous person has a lifespan that is 18 years less than any other Albertan, like almost 20 years less. And this is my personal journey. We call it Truth and Reconciliation, so I'm bearing my soul to you about that. I wasn't responsible for it, but I do own maybe some repair in it, and talking about it is the first step for us. So that's similar to like 1930s era. That's the life expectancy of an Indigenous person, or countries like Afghanistan or Niger. What else did I want to tell you about that? Oh, yeah, that's good enough. I won't tell you about the systemic racism in our health system that we're really trying hard to improve upon. So there's lots of examples about systemic racism, assumptions that an Indigenous person is under the influence of alcohol when actually they could be in diabetic ketoacidosis, things like that. I think I'm doing really good for time. So I'm going to get to the primary care strategy now. So I told you in Choosing Wisely, we started with broad engagement of all clinicians, and then started doing campaigns, and those campaigns they're a little bit easier to do in the hospital because there's 4 walls, the data sets are more obvious, the people there and the support to do that work is all there. And primary care in Canada is broad and diverse, and there's 40,000 family doctors in Canada, and how do we, herd those cats? It's impossible. But we're working on it now. So we have a primary care council for Choosing Wisely Canada. We meet about quarterly, and we talk about sort of important local things that are happening. We try to share good information. And we've started to recognize this campaign around workload. This is all the rage. I think it's all your rage as well, the talk about the workload of a family physician. So this is the campaign that we're about to launch at our national meeting, and you're getting a sneak peek. Part of our strategy will focus on the bottom of this slide. We've got the awareness. We're in the medical schools. We go to conferences. You probably can't meet a family doctor trained in Canada that doesn't know or hasn't heard about Choosing Wisely. We work on alignment and embedment, and that is like partnering with other parts of the health system that are really relevant. We really want to measure this change. We want to have a big impact, not a small impact. And we recognize we're working on a recognition program. So we want a Michelin star for family medicine clinics that are Choosing Wisely. And my colleagues in Quebec are leading the way and trialing something that we hope to scale and spread. And so the spirit of that is that kind of inspires you to be proud of the work that you're doing. It also inspires competition, and who doesn't like a bit of friendly competition from clinics? We got ours started, you get yours. So we're looking very forward to that experiment. These are the commitments of our primary care council. So we really want to integrate the patient perspective. We want to operate under the principle of health equity. We'll seek measurable impact, and we want to adhere to the quintuple aim framework. Probably more relevant to you as the family physician listening to me, we don't want this to be more work for you. you if you're Canadian family doctors, we want this to be easy. This should be easy. We want it to be, we want you to have a high likelihood of success. So you have to be ready to adopt this sort of stuff, and we want to have big impact. I am definitely not going to read through all of our recommendations, but I will highlight number 5, which is around fracture risk reduction or bone mineral density for osteoporosis screening. And all of our recommendations start with the words don't. Do not. Do not order a dual energy absorptiometry DEXA screening for osteoporosis without doing a fracture risk calculation. And I'm just highlighting that one because it's one of the 3 tests that we're targeting in our workload burden. On this slide, the imaging for low back pain. I don't know if you guys do this here, but we still have doctors that order back x-rays for mechanical low back pain with no red flags. So do not do imaging for low back pain unless there are red flags. And then this one, the one I'm going to highlight is the don't do annual screening blood tests. So the annual CBC unless there's an indication by from the patient's profile. And I'll come back to those 3. All of these lists are on our website, so if you want them, you can go to the Choosing Wisely website as well. In the spirit of guidelines, I wanted to highlight my favorite guideline ever. This is the Peer Simplified Lipid Guideline. The peer group is a group out of Edmonton, Alberta, that are a group of family physicians that are creating evidence-informed guidelines for family physicians. So looking at all the evidence, and the research still might not be on the patients in family medicine, but they're reviewing all of the evidence, and they create these simple guidelines. And obviously you can't read that, but here's the bottom line. I say to my patient says, I think I should have blood work. And they'll say, what blood work do you want? Well, maybe my cholesterol. And I'll say, would you ever take a statin? And they say no. And I'll say, well, then I'm not going to check your cholesterol. And if they say, well, I might, then I'll say, okay, let's check your cholesterol. We will not do your Lp(a) like the Canadian Cardiovascular Society guidelines suggest, because that doesn't actually add very much. But we'll check a lipid panel, and then we'll do a risk assessment. And if the patient is considered low risk, we'll check it again in 3 to 5 years. If they're moderate risk, we'll talk about the harms and benefits of statins, and I'll try to help them make a decision if they want to take a statin. If they're high risk, we'll have that same conversation and try to help them. I'll encourage them to maybe more to take a statin if they're high risk. And then if they say, yeah, I'll take the statin, I'll put them on the highest dose that they tolerate, and I'll never check their lipids again. And sometimes they'll say, but I want to know if it's working. And I'll say, I promise you it's working. And then they'll say, but can we check next year? And I'll say yes. And then if they don't come back, I won't call them. So we still get away with not rechecking the lipids. And in my practice, we work as a team. We all have our own patients. We value that continuity. But I could only be here because Ingan is checking my inbox at home. So when I'm checking my colleague's inbox, I feel it. I have to look through the chart. I'm like, why did you order this test? Oh my God, I can't stand this. And so I'm trying to be kind to all of my colleagues that are checking my inbox by not ordering all these tests. I just wanted to highlight these 3, we call these toolkits. So we have our lists, we have our campaigns, we have our toolkits. These are 3 toolkits that outline management of a certain condition and then maybe make a quality improvement project easy for you to do. We have mandatory quality improvement. When I get my license every year, I have to check a box that says, yes, I've done quality improvement. So the first one, called Less is Best, is about not doing a chest x-ray for a child with bronchiolitis. That is a clinical diagnosis. The gold standard is our upper respiratory tract toolkit. Outlines the symptoms of viral upper respiratory tract, what might be bacterial. If you do decide to give antibiotics, to only give 5 days, not 7, not 10, shorter courses. And then the new and improved toolkit that is launching in January, which I think might be aligned with one of your recommendations around proton pump inhibitors, is the Ask Why for PPIs. This used to be called Bye Bye PPI. But we've had a big committee looking at this toolkit, and they've renamed it. I don't know why I haven't seen this, but we have a webinar in June to launch that. Okay. I'm going to whip through this. We're working through the workload wisely, so this new campaign in primary care to reduce a clinician's workload. We're focusing exclusively on clinical tasks or unnecessary clinical tasks. In Canada, unnecessary administrative tasks that come to the doctor are tasks that you don't need a medical degree to do. So it doesn't include like your charting, because that's actually part of your responsibility. When you see a patient, that's not considered administrative. That's like an indirect patient task. So that's what we're focusing on. From the clinician perspective, these unnecessary tasks take away time from either getting home for dinner or the necessary volume of tasks or the value-based care that we would like to be providing, and it might increase our burnout. From society, there's effective cost and impact on the planet. I don't want to speak for Tony, but this is the slide created by our patient partner around the patient perspective on reducing physician workload. So it's really important our patients buy in and don't feel that we're just trying to do a cost-cutting measure to them. This is for them as well. I feel so weird having this slide here. I really would like to have coffee with you, Minna, if you're here, because you're a rock star in Canada. So Minna first presented her work at the Preventing Overdiagnosis conference in Calgary, and we talk about Minna all the time now in my circle of friends. So Minna joined one of our working group meetings, and my friend texted me, "That's Minna Johansson." I said, "I know." And we were like, "Oh my God." So now I can go back to Canada and say, "I met Minna Johansson." And all of you, because you're all famous. But so we use this quote all the time. And so this concept of the time needed to treat, I don't think I need to tell you about. But what I want to tell you about is that, again, my very smart colleagues in Quebec, Choosing Wisely Quebec, have created just a tool for individual clinicians to estimate the time that they're spending on unnecessary tests. And so it's free, you can use it. And we landed on a tool because when we thought, well, if I've been working for 25 years, it takes me 2 minutes to do something. I've been working for 1 year, it might take me 20 minutes to do something. And so we didn't want to publish these time needed to treat or time needed to save hours or minutes that don't resonate with people. So if I said to you, well, I could save 2 weeks in 5 years by not doing this test, someone else might say, well, it doesn't take me that long, I'm just going to do it. So, or I disagree with you, and you can just enter, it's like a little QI for yourself, where you can enter information about how many patients it impacts, and it'll give you a calculation. And so the back of the napkin estimate for not doing bone density from filling out typing out a requisition, getting a result, reviewing it with a patient is estimated to be about a week of time in a 25-year career. And so that you got the sneak peek. At our meeting at the end of May, we'll be talking about our workload burden campaign. And then I'm just going to end on Choosing Wisely Canada's role in the international community. And so all of these international communities agree when they want to have a Choosing Wisely initiative to be clinician-led, to focus on quality of care, not cost of care, to include patients, to be evidence-based, to be multi-professional and transparent. And Choosing Wisely Canada has an international learning network starter toolkit that we support. And I just think it's a beautiful slide because we're all the same, but we're different, and look at all of the countries that are involved. And with that, we have 2 minutes for questions, maybe.